Hmm. Hmm.
There is no one. Should I join your live
Yes.
from here?
Hmm.
I will come. Is there any way you can blur your video? That you can just be on mute.
Good evening. Am I audible and visible? Please do let me know, because this is my first YouTube live session. There will be glitches, there will be issues, but I can promise it's only going to get better from here. Am I audible? Am I visible? For the ones who are joining in, just write your comments.
Do like.
Okay. So I hope I am audible and visible. And this series of sessions, which I have started and I've thought of starting since a very long time, but then I couldn't because of exams and other commitments that I had to, like take up. But this is one series which I'm starting today. I know it's very unprofessional, let's say, the least. A lot of glitches, a lot of unknown things. I think That's what happens when we begin something. But I'm just doing it for the sheer love and passion that I have towards teaching, and that is exactly what brings me here. Uh, as for the ones who do not know me, I'm Dr. Navonil Datta from West Bengal, and I have completed my. I'm a doctor of 2015 batch from Bakura Samilani Medical College and Hospital, West Bengal, and I've completed my internship in 2021 and also my NEET entrance in March 2023. So I will try and take you through this journey of the phase that I have been through over the last 1.5 years, and I'll try helping my my fellow colleagues, my friends, my juniors, and all the ones who just want to join in with me in this journey of making things a little more bearable. This entire phase, these entire sessions are all about keeping them as light, as concise as possible. We're starting with obstetrics today. Every week, I'll try to come up with a certain amount of content which is going to be extremely high yielding for all your exams, be it NEETPG, be it your INICET or be it your FMG. As we know, कि exam कोई भी हो, the topics are always going to get repeated. The the manner of the questions is all about, I mean, as long as it's about the options getting twisted, the language of the question, it can be twisted as much as you can. There's no end to it, but then the topics more or less are always going to be the same. So I'm going to take up a very basic topic today, and we're going to start off with obs. And the basic topic is a basic antenatal care in pregnancy. I'm going to talk about the vaccines that are to be given in pregnancy, the ones to be avoided. I'm going to talk about certain placental hormones and also the aneuploidy screening. So, four important high yielding topics which we are going to begin today. And I hope that, whoever is watching, I hope you share this with your friends and colleagues. And I hope that, we can all make this session very interactive. So, in the upcoming sessions, I'll be really loving to find more people participating in here, writing different things, maybe posting up your doubts, and I'll be really happy to help you all as much as I can to the best of my capacities. I will always try to cater to you. So let's begin with this. I just need a basic confirmation without about whether my audio is up to the mark, whether you're able to hear what I'm saying. So if anyone would be kind enough to just let me know. Otherwise, I'll be like beginning in a couple of minutes. Okay. I have the first one who's commenting, Dr. Janvi. Hi, Janvi. Good evening. Thank you. Thank you for the confirmation. I think we're good to begin. Uh, so I just want you to sit with a plain paper or a copy, and just write down whatever I am saying, because I think every time we are having lots of resources, lots of books, everything is there. But then what I'm trying to say is the reason why I'm going to take these sessions is I want you to understand that when you sit in one place, when you have your pen and paper and you hear someone and you just write down those points in a concise manner, because you are the one who's writing it, it is always going to help you. Okay? So I'll be keeping the language as predominantly English, because I know everyone is not comfortable with Hindi. I myself am a Bengali, but then I'll also speak Hindi beech beech mein. Okay? I hope, and I can promise you, if I'm saying something in Hindi, I will also at the same point of time say it in English, or else it's going to be a joke or maybe something which I will try to incorporate to it in order to make it as simple as possible. So, in case someone is not understanding that Hindi part, you can be assured that it's not something which which is catering to the portion. Okay, so we are good to go. I would absolutely love. Okay, Janvi, I have Dr. Vijay Lakshmi. Welcome, welcome. It's an absolute honor for me to have you all here, and you can share this with your friends. The recorded version will remain. You can keep on sharing with your friends, and anyone who's getting benefit out of this, I will be absolutely glad and happy. So, as I said, we're going to begin it very soon. Just keep a piece of paper and a copy with you, and just write down whatever I'm saying. So, whenever I am talking of obstetrics, it is mainly going to deal with pregnancy, the physiological changes of pregnancy, the pathological features associated with certain disorders in pregnancy, the pathophysiology, and the management of them. So that is exactly what pregnancy is. And believe me, obs and gynae forms a huge chunk of any competitive exam. At least 20-25 questions on the whole, every paper. Even in this year's INICT, 2 days back, a good chunk of questions from OBGY, and even in the NEET, which was conducted in March, we had a good chunk of questions from this subject. So that's how it is. The topics are always going to be repeated. One basic topic, which is, I feel, often ignored and not maybe understood well, or we do not have a concise format of this. I'm going to take up that. And as I said, the topic is antenatal care in pregnancy. So whenever we talk of antenatal care in pregnancy, we know that we are having three phases in a pregnant female. One is the antenatal phase, so one is the intrapartum phase, and the other is the postpartum phase, right? So as we talk of antenatal care in pregnancy, what are the points which are specifically asked in our entrances? हमें सिर्फ उतना ही फोकस करना है जितना पूछा जाता है, और उसको बार बार देखना है, उसको बार बार पढ़ना है. मैं बार बार बोल रहा हूँ, the secret to doing well in your entrances is revising the same thing over and over again. So whatever I am teaching you at this point in time, or whatever I'm discussing with you, your work is to just layer it up with the PYQs and the questions from any resource that you have, and just make that one little concise page of everything. So I want to make every topic of OBS that I teach in one page. So as of now, I begin with antenatal care in pregnancy, and the first basic questions जो बार बार पूछा जाता है कि what is the minimum number of visits which are to be made. So we have two guidelines. एक तो WHO से आता है. So under WHO, 8 minimum visits are recommended, whereas the government of India recommends a minimum of 4 antenatal visits. This is one PYQ which has been previously asked. So 4 visits minimum for government of India, 8 for WHO. In an ideal setting, however, we need to have more number of visits. So till 28 weeks, we say that the female should report to us at least 1 visit per month till 28 weeks. Between 28 to 36 weeks, it's once every 2 weeks, and beyond 36 weeks, it is once every week. So these are the ideal visits. But then सवाल हमेशा यही से आता है कि minimum number of visits कितना है, and the answer is government of India recommends at least 4 minimum visits. Now, the second question regarding the caloric requirement, जो कि एक integration है with PSM, and once again different sources coming up with different values. So once and for all, let's just get it settled. So the caloric requirement, as Park says, is an addition of 350 kilocalories in all the trimesters. So in all trimesters, you have an additional 350 kilocalories, sorry, that is to be given. However, the national guidelines say that, and mind it, it's the national guidelines which are more often asked. So national guidelines say that in the first trimester, I'm going to add 70 kilocalories per day. In the second trimester, it's going to be 230 kilocalories per day. And in the third trimester, we're going to have an addition of 400 kilocalories per day. So 3 values, 70, 230 and 400. इसको रफ याद रख लो. Exam direct याद नहीं भी रख सकते हो. रफ याद रख लो. It will help you. It's often the national guidelines which are asked. However, INICT, once upon a sudden while, they keep on asking some weird questions. So for INICT, they do ask sometimes the ACOG guidelines. The ACOG guideline says that in first trimester, you do not need to add anything. So it's 0 kilocalorie per day. In the second trimester, it's around 350. Whereas in the third trimester, it's around 450 kilocalories per day. That is how the caloric requirements are. So we have done 2 important PY sections. One is the antenatal visit, one is the caloric requirement. The third one, what is the recommended weight gain in pregnancy? Now, why is this important? Because in females with low BMI or in a female with higher BMI, it is associated with certain prognostic responses of the fetus. So those pregnancies can be high risk based on certain other reasons. It's not that a female with a high BMI is a high risk pregnancy, no, but high BMI often predisposes to certain placental pathologies, certain uteroplacental pathologies, which can lead to the pregnancy becoming a high risk pregnancy. So that is exactly where we need to be a bit cautious. So the recommended weight gain in pregnancy for a normal BMI female, that is, a normal BMI female is someone who is in the BMI range between 18.5 to somewhat around 22 or 23 maybe in the Indian setup. So someone in this, the normal weight gain should be somewhere between 11 to 12.5 kgs. So 11 to 12.5 kgs. However, with females with a lower BMI, that is a thin female, you can say that a weight gain between 12.5 to 18 is absolutely fine. However, in a female with a larger BMI, an obese female who or a BMI with more than 30, as we say it, any weight gain that is normal is something between 5 to 9. We can keep it an average of 7. Not need to remember it for all categories. Just remember that 11 to 12.5 kgs, that's the minimum amount of recommended weight gain that we have in pregnancy. So 3 questions sorted from here. Now as we come into mm, the part where we will be now talking about not just the caloric requirements, but we'll be also talking about the antenatal investigations that we need to do, the care that we need to take when a female is presenting to us for the first time in an antenatal visit. Okay. Now, two very important questions that I need to cater to. First thing is, because we took up the PSM wala part in the initial stages as to the weight gain and the caloric requirements, let's also talk about folic acid in pregnancy, and let's also talk about the recommended dietary allowances of certain important elements. So starting with folic acid, extremely important questions. Jitna main bol raha hu, just write it down, keep it in a piece of paper, and keep revising it till the last day. And trust me, whatever I'm saying, you will need it even till the last day. So if in the last day you need to revise something of obs and gynae, this will be more than sufficient information that you can store in your head. If you can keep something more, it's always great. So folic acid in pregnancy, you need to know that why is folic acid being given. Folic acid is given to a pregnant female to reduce the risk of neural tube defects. So to prevent a neural tube defect, please read the question carefully. Agar question पूछता है what is the dose of folic acid in pregnancy for prevention of neural tube defects, the answer is 400 micrograms per day. When do you start it? You start it 1 month before conception, and you continue it 3 months till 3 months after conception. So for preventing an NTD, that is a prophylactic dose, I am going to give a 400 microgram per day. If I am to give folic acid for preventing the recurrence of NTD, for example, the question says that there was a female and this is a second pregnancy. In the first pregnancy, she has the risk of, she has a history of delivering a fetus with spina bifida. And what is the dose of folic acid now that you will be giving to this female for preventing the recurrence of NTD in this female? The answer is going to be 4 mg per day. Naturally, dose zyada hoga. So 4 mg per day is then given. This time we start this folic acid 3 months before conception, or from the day of, or from the day the female is going to plan her pregnancy. We start it from them and we continue it 3 months after conception. So either on the day she decides to have it, conceive, or 3 months before to 3 months after. That is the range in which we give 4 mg per day of folic acid. Now, what is the dose of folic acid that we give to a mother who is already having a folic acid deficiency? So for a mother who is having folic acid deficiency, we need to give 1 milligram per day, 1 mg per day folic acid. Okay? So 3 doses. One is to prevent NTD, 400, to prevent recurrence, 4 mg per day, and to treat folic acid deficiency, 1 mg per day. Is this good enough for the ones who have joined in? I hope that whatever I'm saying, whatever I've been saying till now is something which you can understand, which you can relate to, and I hope you're writing it down in one page. So now, in diabetic patients, we know that this is one more topic which is extremely important. Be it from gynae, be it from pediatrics, it's an extremely important topic in front of a diabetic mother. So whenever we talk of diabetic patients, especially the ones who are having over diabetes or pre-gestational diabetes, for those mothers in their pregnancies, we have a subsequent risk of developmental anomalies. As we know, the most common developmental anomaly that occurs is a CVS anomaly, and the most specific one is a neural tube defect, and the most specific neural tube defect that we have is caudal regression syndrome or sacral agenesis. These are 2 independent PYQs which have been tested before. So as I said, most common abnormality is a CVS anomaly, and most specific anomaly is a neural tube defect, which is a sacral agenesis or caudal regression syndrome. Among CVS anomalies, which is the most specific, it is transposition of great arteries, TGA. ठीक है, इतना should be done. Now, because diabetic patients are already having a higher risk of development of a pregnancy which is at a high risk, where the fetus can have NTDs, that is neural tube defects, the dose will be similar to what I have been giving in a normal person to prevent neural tube defects. That is 400 microgram per day. So अगर diabetic दिया हुआ है question में, तो dose बढ़ा के 4 नहीं लिखना है, ठीक है? तो 400 microgram per day is the dose that is given to any normal pregnant female to prevent NTD. It is the similar dose that we are giving to any diabetic female as well to prevent NTD. Dose, when are we increasing the dose? From 400 microgram to 4 microgram we are doing when we need to prevent the recurrence of an NTD, number one. And when are we giving 1 milligram per day? It is to treat folic acid deficiency in a female. Okay, now in patients who are on anti-epileptics, now another section which has been tested previously, names also in JIPMA, in a patient who is already on an anti-epileptic, before conception you need to give 400 microgram per day, as I said, and after conception you need to give 4 milligrams per day. What is the dose that you need to treat sickle cell anemia? It is 5 milligrams per day. So these are the few values. So for sickle cell anemia, it's 5. For patients on anti-epileptic, before conception, it's 400 microgram as we were giving to a normal female. But after conception, it's 4 milligram per day, because we need to prevent recurrence of neural tube defects in the subsequent pregnancies. Now, what is the recommended dietary allowance of iodine in pregnancy? It is 250 micrograms per day. 250 microgram per day is the recommended dose of iodine. Calcium requirements is 1000 milligrams per day, and whatever I'm saying, you can trust me, and these are the latest guidelines from the national updates, so you can just write this down. If there's any change in the updates, वो तो बाद में देखा जाएगा, and you'll be updated accordingly. But as of 2023, the guidelines that we have is an iodine is 250 micrograms per day. The calcium requirement is around 1000 milligrams per day. And the only thing which which I will tell you, which I will tell you to remember maybe, is the protein requirement, where I feel that in the third trimester, जो पूछा गया है पहले, in the third trimester you need to have an addition, the female needs to have an additional 20 grams of protein. ठीक है? So additional 20 grams of protein in the third trimester is what you need to understand. Okay, so that sorts out at least 4 areas of integrated OBGY and PSM areas, which I can say are frequently tested. What is the second part? This is also an integration with OBGY and PSM, where we are going to talk about vaccination in pregnancy, and I'm going to talk of which should be given to all pregnant females. I'm also going to talk about exercise, about sexual intercourse activities, and air travel in pregnancy. So these are questions which generally हम लोग तो बहुत ignore करते हैं, ये पहला section of ops. So please don't ignore. There are times that the institutes, especially the central institutes, are going to ask you stuff like this, and maybe they're going to frame 4 options, and will be asked to mark the correct or the incorrect statements, as in 1, 2, 3, or 1, 3, 2, 3, as in multiple options, as INICET loves asking these days. Excuse me. Okay, so the vaccines which should be given to all pregnant females, the first thing, very important, is a TD vaccine. So tetanus and diphtheria vaccine, all pregnant females should be given this vaccine. How many doses do we give? We give 2 doses of this. First dose to be given at the first antenatal visit, and the second dose is given after a gap of 4 weeks. So please listen to it again. The first dose at the first antenatal visit, the second dose after a gap of 4 weeks. If the pregnant female was immunized in the past 3 years and has received these 2 doses, then in the current pregnancy, only 1 booster dose is needed. So when do I give a booster? If only the last pregnancy was within the last 3 years. Otherwise, I will again, if the female is becoming pregnant after a span of 7 years, 8 years, I will have to repeat the same schedule of TD vaccine, that is, give the first dose at the first antenatal visit, the second dose give it after a gap of 4 weeks. The second vaccine is TDAP vaccine, which is a tetanus toxoid, a reduced diphtheria toxoid, and an acellular pertussis component. And what is recommended is at least 1 Tdap vaccine, that is 1 TDAP vaccine, should be given between 27 to 36 weeks to all pregnant females to protect the newborn from pertussis. The statements that I'm making right now, please make sure that you're writing every statement. Every statement that I'm saying right now is a potential question. So 1 Tdap vaccine to be given between 27 and 36 weeks to all pregnant females to protect the newborn from pertussis. The third vaccine, which is given, is an influenza vaccines, regardless of the trimester, regardless of which trimester she is in, during the flu season, especially in the seasons between October and May, between October to May, which is the predominant flu season of India. The every pregnant female, regardless of her trimester, should receive the influenza vaccine, and one dose is given intramuscularly to the pregnant female. As far as the new disease that has been rocking the world and shocking the world over the last few years, thankfully this is under control right now. The WHO has declared that it's no more a pandemic. Our very famous, our very own COVID-19 vaccine. This vaccine can be given in any trimester if the pregnant female has not received it earlier. So if she has received it earlier, then she doesn't need it during her pregnancy. Otherwise, she can have this vaccine being given in any trimester. So 4 vaccines: TD, Tdap, influenza, and COVID-19. COVID-19, any trimester if she's not received it before. Influenza between October to May, at least 1 dose IM. Tdap to protect the newborn from pertussis, where we are giving the pregnant female this vaccine between 27 and 36 weeks. And the TD vaccine, which is the tetanus toxoid, along with the diphtheria toxoid, which I'm giving on the first antenatal visit, and the second dose I'm giving it after 4 weeks. If she has received it within a span of 3 years, then only I'm going to repeat a booster dose. Otherwise, I am not going to repeat a booster. I'm going to repeat the entire schedule. Okay, that's what is about vaccines, which is commonly asked. Now, vaccines which are safe and vaccines which are absolutely contraindicated. Let's make a little list of these two things. Vaccines which are absolutely contraindicated. All the live vaccines, as you know, will be contraindicated in pregnancy. So MMR vaccines, measles, mumps, rubella, is contraindicated. Smallpox, chickenpox, BCG, and HPV vaccines, all of these 4 vaccines, along with MMR, are going to be contraindicated in pregnancy. Vaccines which are safe are all the dead vaccines. So Hep A, Hep B, pneumococcus, the meningococcus vaccines, and the rabies vaccines are the ones which are going to be safe and can be safely given to a pregnant female. So that's all about the vaccines. And one more list which is often asked at times: vaccines which are given in special circumstances. So in very special circumstances, we can give, for example, if there's a polio epidemic or a polio outbreak has occurred, will the mother receive a polio vaccine? Yes, she will receive a polio vaccine, the inactivated polio vaccine, not the oral polio vaccine, which is a live one. So the special circumstances account for 3 vaccines, which are yellow fever, the typhoid, and the polio vaccines. So these 3 vaccines can be given under special circumstances. Otherwise, we are not going to give these vaccines. Now, what about exercise in pregnancy? What about air travel in pregnancy? What about sexual intercourse in pregnancy? As far as air travel is concerned, ACOG, the American College of Obstetrics, recommends that air travel should not be done beyond and over 36 weeks of pregnancy. Until then, she can undergo air travel, provided that she is having a normal pregnancy. Exercise in pregnancy, moderate exercise is recommended. However, for females who are having heart disease, lung disease, pulmonary hypertension, a risk of having a preterm labor, risk of premature rupture of membranes, placenta previa, uteroplacental insufficiencies like pregnancy-induced hypertension, significant bleeding has occurred during her pregnancy. In those circumstances, we do not recommend exercise. Otherwise, moderate exercise, that is for around 150 minutes per week, is recommended by ACOG. What about intercourse during pregnancy? Sexual activity is actually not contraindicated in pregnancy. A female can have sexual intercourse. However, in certain cases of threatened abortion, in cases of preterm labor, premature rupture of membranes, and a low-lying placenta, that is placenta previa, in all of these cases, sexual activity is to be prohibited. Okay, these are basically some areas which I wanted to talk of. In the end, after I finish off with the section of obstetrics, I would love to, speak in a very tabular format about the government of India recommendations for a high-risk pregnancy. What are the conditions which the government of India cites specifically as a high-risk pregnancy? And if you remember, 2 years back, a similar question in NEET had come, where they had put one question on OBS, one question on gynae, where they had said, what is a high-risk neonate as defined by the government of India, and what is a high-risk mother as defined by the government of India? So these questions do keep on coming, and I think not just as people who are preparing for these entrances, I feel even as a doctor, it's very important for us to realize the high-risk cases and be a little cautious about them when we are doing our clinical practice. So that sums up the majority part of the PSM integration with OBS that I could do. and I could think of. All the PYQs have been included. Your work is to just, as I said, listen to this, make your notes, and just solve the PYQs. Now, coming to an extremely important part, which is always tested, will be tested eternally. It's going to be the aneuploidy screening. Now, whenever I talk of aneuploidy screening, I need you to understand that aneuploidy screening is, number one, done to see the risk of the fetus developing gross congenital anomalies due to some genetic disorders or some metabolic disorders. So if I'm talking of aneuploidy screening, I can divide it into a first trimester screening and a second trimester screening. Okay, for a first trimester screening, just write down, you can divide it in two ways. One is a radiographical screening, which I'm doing via USG, and the other is a biochemical screening, which I'm doing by sending her blood to the labs for checking certain lab parameters. When I'm talking of biochemical tests, we have a dual test. So in the first trimester, under a biochemical test, we are going to have a dual test. What is the dual test going to comprise of? It is going to comprise of a PAPPA, that is PAPE, and an HCG. So how do I remember कि कौन सा चीज किसमें बड़ा होता है? HCG, the name has H, it begins with H for high. So HCG remains high in the dual test, and PAPE naturally becomes low. So high HCG is found in if there's high HCG which is being found, then it is more specific of the fetus having a high risk for developing Down syndrome. Okay, so under biochemical test, a dual test, as I said, has two components, PAPE and HCG. If I'm talking of Downs, HCG will be high, PAPE will be low. And as I said, apart from biochemical tests, we are also going to do a radiographical test, that is USG. When are these two tests done normally? So in the first trimester, between 11 to 13 weeks, that is the recommended time in which we are going to do these tests. And what are we seeing in the USG? Basically, we are going to see this parameter called a nuchal translucency scan. So what is nuchal translucency? So the baby is lying down like this, and I am seeing that below the neck of the baby, there is a certain fold of thickness. So this amount of thickness that is there as in the neck fold of the baby is what I called a nuchal translucency. That is picked up on the USG between 11 to 13 weeks. Anything that is beyond the 3 millimeter in size, then it has a higher risk for the development of congenital anomalies. So always remember that a nuchal translucency scan, which is the value which is more than equal to 3 millimeter, indicates aneuploidy. What is the most common aneuploidy that we come across? It's Down syndrome, that is trisomy 21. Apart from this, we can get trisomy 18, we can get trisomy 13, we can get Turner's, or we can also have the possibility of a congenital heart disease. So now, a question that often is given to us to confuse, if I am finding that on the NT scan, the value is more than equal to 3 millimeter, what is the next step? I will definitely confirm it by doing a karyotype, right? If the karyotype is normal, what is the next step? So ये जो next step वाले questions है बहुत बार आते हैं. So take care of these questions. So the first question is, if the NT scan on USG is more than equal to 3 millimeter, what is the next step? It's a karyotype. If the karyotype is normal in this case, what is the next step? The next step is always going to be a fetal echo, because as I said, if I'm going to rule out the causes apart from aneuploidy, the other thing that NT tells us is gross congenital CVS anomalies. So the next step of a female who is having a higher NT scan value in the first trimester, but a karyotype is normal, the next step is always going to be a fetal echo. In the second trimester, we are going to have screenings, which will again be a biochemical screening and radiographical screening. Under the biochemical screening, unlike the first trimester where we had a dual test, this time we are going to have a triple test and a quadruple test. Triple test, 3 parameters. HCG is common, so HCG is going to be high, as I said. The other 2 parameters are alpha fetoprotein and unconjugated estriol. So unconjugated E3 and alpha fetoprotein. See, alpha fetoprotein has a lot of ALL for low, so alpha fetoprotein is going to be low. HCG, say high, is going to be high, and unconjugated estriol is going to be low. So these are the markers of the triple test to detect aneuploidy. And for a quadruple test, we are just going to combine the findings of these triple tests, that is alpha fetoprotein and the HCG and the unconjugated E3, with another test which is inhibin A. Please note it is inhibin A and not inhibin B. Isko galat mat karke aana, it is inhibin A. Inhibin is increased. So what are the parameters which increase in the quadruple test? Inhibin increases, HCG increases. What are the factors which decrease? Alpha fetoprotein, alpha has L say low, it is low, and your unconjugated estriol is again low. So these are the components of the triple and the quadruple test. Repeatedly has been asked in INICE and NEET exams over the last few years. Okay, what are the USG markers? The USG markers are mainly going to be soft tissue markers like nuchal fold thickness. Nuchal fold thickness beyond 6 millimeter. This is not a nuchal translucency, but it is a nuchal fold thickness. A nuchal fold thickness which is more than equal to 6 millimeter. We can have an absent nasal bone. In the next session, I will be trying to integrate all of this with images that I have. Because it's my first YouTube live, I really do not know if screen sharing is possible. If screen sharing is possible, I will absolutely be glad to do that. So if any one of you who is watching this is a tech savvy person, you can let me know if screen sharing is possible via YouTube live. I would be happy to integrate those images there. And so as I was saying, the USG soft tissue markers include the nuchal fold thickness, which is more than equal to 6 millimeters, an absent nasal bone, a short femur or a humerus. At times in females, at times in babies who are having a higher risk for Down syndrome, we have a single crease on the palm, which is called a simian crease. We can also have duodenal atresia, which is found a sandal gap. Sandal gap is nothing but a gap between the fourth and the fifth metatarsals. Okay, so gap between the fourth and the fifth metatarsals, there will be a gap like this, and this gap is called the sandal gap. Absent nasal bones or nasal hypoplasia, an echogenic bowel, and a choroid plexus cyst. Choroid plexus cyst, please remember this term, a choroid plexus cyst in isolation. अगर मुझे कोई भी pregnancy scan में choroid plexus cyst दिखता है, only choroid plexus cyst without any other USG soft tissue markers, then this has the lowest risk of aneuploidy. So if you're asked which is the soft tissue marker, which if present in isolation has the lowest risk of aneuploidy, it is choroid plexus cyst. Now, what do I need to see? In this entire system of scans that I said about the lab parameters and the USG findings, so in the second trimester, if I'm subjecting the female to a biochemical test and the USG soft tissue findings, as I said, any two out of the soft tissue findings should be present, along with either a triple test positive or a quadruple test positive. That is what the guidelines say. Okay, certain important points that I want to say is what do I mean by a combined test? Combined test means using a biochemical test and a USG in the first trimester. What do I mean by an integrated test? Integrated test means I have done a certain test in first trimester, a certain thing in the second trimester. So what do we do in the first trimester for an integrated test? We're going to do a PAP-A. What is the value of PAP-A going to be in aneuploidy? It's going to be low, correct? So PAP-A in the first trimester done with USG for nuchal for nuchal fold thickness in the second trimester, along with a quadruple test, which includes alpha fetoprotein, inhibin A, HCG, and your alpha fetoprotein, HCG, unconjugated estriol, and inhibin A. All these four tests, which are the quadruple tests. So quadruple test in trimester 2, your USG for nuchal fold thickness in trimester 2, as well as a PAP-A in trimester 1. All of these three combined forms the basis of integrated test. It's not something that you need to remember, but at times if you're twisted on this regarding these tests, this is the maximum twist that you can get. So if you are asked about a combined test, it's a biochemical test along with a USG in the first trimester. And that's a dual test and a USG test in the first trimester. And if I'm talking of an integrated test, it's a PAP-A in the first trimester along with a quadruple test in trimester 2, along with USG for nuchal fold thickness in trimester 2. Okay, now what about the aneuploidy screening? How do I go forward with the female in whom I am wanting to rule out aneuploidies? So in all pregnant females, irrespective of their gestational age, I will see whether the screening tests that I talked of. What are the screening tests I talked of? I talked of the screening test in the first trimester. I talked of the screening test in the second trimester. Irrespective of what is the gestational age of the patient, in her I will always, I mean, not the gestational age, but the age of the patient, irrespective of the age of the mother, I will always start the screening test in the first and the second trimester. If the screening test is positive, the next question is, what is the next step if the screening test is positive? The answer is always going to be karyotyping. Please remember, dual test, triple test, quadruple test, integrated test, USG tests, these are not diagnostic of aneuploidies. These are only screening tests. If the screening test is positive, then we go for a diagnostic test, which is karyotyping. From where am I going to obtain the tissue for karyotyping? The tissue for karyotyping is going to be obtained either by a chorionic villus sampling or an amniocentesis. We are going to do a chorionic villus sampling, that is CVS, in the first trimester and an amnio in the second trimester. So what is the ideal time where I can do chorionic villus sampling? It's 11 to 13 weeks. Always remember, 11 to 13 weeks is the time in which you need to do a CVS. What happens if I'm doing a chorionic villi sampling around, say, 8 weeks or 9 weeks? It is done. If an early CVS is done, it is associated with limb defects, limb hypoplasia. What is the karyotyping tissue that we take in the second trimester? It's amniocentesis, and amniocentesis is done a little later, that's around 16 to 18 weeks. If it is done early, it is associated with high fetal mortality. So early amnio is no more recommended. Earlier it used to be done in certain circumstances, but early amnio is no more recommended. It is always CVS between 11 to 13 and amnio between 16 to 18 weeks. Now, in which test will I obtain faster results? Fast is positive. As I said, my next step is going to be karyotyping. What if the female says, I do not want to do a karyotyping? In this case, I will undergo a second test, which is called a non-invasive prenatal test, commonly called the NIPT. So in NIPT, again, I'm repeating this. Screening, any patient comes to me, she's pregnant, irrespective of her age, I will put her to the screening test. Screening test positive via, what is the next step? Always it's going to be karyotyping, which is the diagnostic form. Either I do a karyotyping by CVS or I do it by amnio. पेशेंट अब बोलता है मेरे को कि आई डू नॉट वांट टू गो फॉर अ कैरियोटाइपिंग, व्हाट इज माय नेक्स्ट स्टेप? इफ the patient does not want to go for a karyotyping, the next step is always going to be an NIPT, non-invasive prenatal testing. What is it? It's a secondary screening test. Once again, I repeat, NIPT is not done as a substitute of karyotype. It is a secondary screening test done. It is not a confirmatory and a diagnostic test. So I'm repeating the statements with a lot of emphasis. Please take a note of all these points. So NIPT is a secondary screening test where we are going to see cell-free fetal DNA. Again, a question which has been asked. I'm repeatedly saying all the words that I'm going to utter in this session today have been all asked before. So what is the tissue what is the substance that we are testing in NIPT? We are going to test cell-free fetal DNA. It can be done anytime beyond 10 weeks, and it has got a very high sensitivity of around 99%. If the NIPT is positive, which means that her primary screening test was positive and her NIPT is also positive, then the next step is always going to be karyotyping. Please remember, there is no bypass, no shortcut to karyotyping. I will only do this NIPT if the female wants to, there are some people who say, I do not want to, take so much of money to do the karyotyping test due to economic reasons. What do I do next? I will always do an NIPT. If the NIPT is also positive with the first test, screening test being positive, which means now that both screening tests are positive, I will do a diagnostic karyotyping in this patient. What if the screening test is negative? I mean, what if NIPT is negative? If NIPT is negative, I will not do any further testing in this patient. I will reassure the patient, you are absolutely fine. We do not need to proceed with any karyotyping anymore. So once again, this flowchart, I do a screening test. I've talked of the screening test before, not repeating them. What is the next step? If its screening test is positive, it's always going to be karyotyping. Tissue obtained is either via CVS or by amnio. Amnio between 16 to 18, CVS between 11 to 13. Early CVS, limb hypoplasia, early amnio, fetal death. Okay. Now, fastest results in CVS. If screening test is positive, female does not want to undergo karyotyping, do a secondary screening test, repeatedly saying it's a secondary screening test, which is an NIPT, non-invasive prenatal test, where we are going to test the cell-free fetal DNA, and it's got a very high sensitivity, can be done anytime beyond 10 weeks. If it's positive, we will definitely have to do karyotyping, which is diagnostic, no shortcuts, no short measures. If it's negative, then we will say that, okay, we are going to reassure the patient that you do not need to undergo any further testing. Okay. Now, if you're asked, these are important PYQs, which I'm saying, one single USG marker in the second trimester, which if present in isolation has the highest risk of aneuploidy. I repeat, one single USG marker in the second trimester, which if present has the highest risk of aneuploidy. It is nuchal skin fold thickness beyond 6 millimeters. What is the second answer? अगर ये ऑप्शन में नहीं है तो शॉर्ट फीमर, ठीक है। आई रिपीट, one single marker of T2. What is T2 doing? It's showing me USG soft tissue parameters. क्या देखना है? One important risk factor is nuchal fold thickness beyond 6 millimeter. अगर वो ऑप्शन में नहीं है तो short femur. One single USG marker in T2, which if present in isolation has the least risk of aneuploidy, is something that I've said before. It's a choroid plexus cyst. ठीक है? I hope you'll not get messed up with these things. About the images, I will try to incorporate the images in the next picture. I mean, in the next session. About the Down syndrome, I'll just have a few basic talks about Down syndrome, and you can just draw a baby, just draw a baby and mark out the organs that I'm saying, and write the associated anomalies that occur. So if I'm talking of, let's go from head to toe in the baby, any baby who is having a Down syndrome, let's go from head to toe. So in the head region, if I start from this, so these babies have a higher chance of being mentally retarded. So mental retardation is one thing. Now coming to the eyes, as you can see, these are the epicanthal folds. So the epicanthal folds are present, and they are going to have a very flat facial profile. The eye sockets are going to be really flat. The tongue is going to be protruding. They often have a protruding tongue. The ear is pretty low set, so it's a low set ear. The neck fold tissue, soft tissue, is abundant, so abundant neck skin. A single palmar crease, as I said, is often called a simian crease. So ऊपर का हो गया mental retardation, epicanthal folds, flat face, low set ears, protruding tongue, and abundant neck skin, and a simian crease. Coming to the heart. In the heart, what is the most common congenital CVS anomaly that can occur in a patient of Downs? It is going to be endocardial cushion defect. Please, this is again a PYQ which has been repeatedly asked. Please take care of this. It's an endocardial cushion defect, which is the most common heart defect which is seen in Down syndrome, followed by VSD, followed by ASD. So VSD is the second most common. It's not the most common. It's always endocardial cushion defect. Now, from intestines, we can have intestinal stenosis in the form of duodenal atresia, jejunal atresia. We can have umbilical hernias. The limbs may be hypotonic because these they are not going to have a proper epiphyseal growth. There may be an abnormal skeleton which is having a poor tone. These babies are often floppy in their lower limbs. A poor tone child, higher risk of higher predispositions to leukemias, and even they have a very high risk of developing childhood leukemias like ALL and AML. The gap between the first and the second toes is going to be more, which is called a sandal gap. So that is these are predominantly the things which are asked from the Down syndrome. Okay, now I'll be just taking up one more topic before I end the session, and those are going to be the antenatal investigations. So antenatal investigations, this topic is not just important for the ones who are going to the entrances, but also for the interns who are working, because when you're working in the gynae ward, in the OPG, in the OBGY wards and the OPDs, we often get a female who is registering her pregnancy for the first time. I mean, it's the first antenatal visit, and we need to know the investigations that we need to order. We keep on pestering our seniors, asking kya karna hai, kya dena hai. For one shot, for once and all, get it sorted. So at the first antenatal visit, the basic investigations that you need to do are all the blood investigations. I'm going to do an ABO. I'm going to do an RH typing. Why am I doing it? ABO मैं क्यों कर रहा हूँ? To know the blood group of the mother. Why am I doing the RH typing? To understand or predict the future possibilities of any RH positive pregnancy if the mother is RH negative. What is also important in this case is the RH status of the father, not just the mother, but more important is the RH status of the father. So ABO RH typing is done. We are going to check the hemoglobin and the hematocrit. Why is this done? Because we need to know the baseline value of hemoglobin, because anemia in pregnancy is a very, very common thing in India. It's one of the very common high risk factors for pregnancy. We need to test out for 2 infections. In fact, 3 infections to be honest. One is VDRL for syphilis, HBsAg for hepatitis B, and we also need to do HIV. So HIV, hepatitis B, and VDRL for syphilis is what is done. Even this time we had a question on VDRL syphilis, where we had a mother who was the wife of a truck driver who had come to us with multiple lesions on her vulva, and we were asked what is the next step. So the next step is always going to be a VDRL. and she was also I mean, the question also gave us a history of having a fetal loss at around maybe 24 weeks, as far as I can recall. So VDRL, HBsAg, HIV, these are the three infections for which we are going to predominantly test. Rubella susceptibility testing is done in some areas, not done in some areas, so I'm not going to stress on that. We are also going to test the diabetes. So diabetes screening is done via the DIPSI method. DIPSI test done at first week, and it's repeated between 24 to 28 weeks. If the patient can afford, only, then we are going to do an aneuploidy screening in the first trimester. I mean, in the first visit. Along with it, we are going to do a TSH levels to rule out hypothyroidism in pregnancy. So these are the investigations which you're going to do in the first visit. Okay, I missed out on something. That's the urine investigation, urine routine and microscopy to be done, because as we move on in the further lectures on OBS, we'll find this that the patients with uteroplacental insufficiencies, preeclampsia, all of them, to suggest end organ damage, urine protein creatinine ratio more than 0.3 is a very significant marker. So urine examinations, that is REME, the three infections screening, the DIPSI test for diabetes, the TSH and aneuploidy if the patient can afford. Apart from that, the basic hemoglobin, the hematocrit, and ABO and RH. That is the basic blood investigations that we're going to do. And at 35 to 37 weeks, we are going to screen for group B streptococcal. How are we going to screen for it? We are going to take a rectovaginal swab. A rectovaginal swab taken between 35 to 37 weeks. We're going to screen for the group B streptococcus. We're going to have a repeat CBC around 24 to 28 weeks of pregnancy. Government of India says hemoglobin must be estimated at least 4 times in pregnancy. So normally, अगर कोई female 4 बार आता है हमारे पास, which is the minimum number of antenatal visits as per Government of India, चारों के चारों बार हम लोगों को anemia के लिए we need to screen out for hemoglobin and her hematocrit. Now, USG in pregnancy, first trimester ultrasound is done for a certain parameters. इसको लिख लो एक जगह पे. Why are we doing a first trimester ultrasound? First trimester ultrasound is done for, number one, for the gestational age assessment, for viability of pregnancy, for suspected ectopic cases, for suspected molar pregnancy cases, for suspected, for seeing how many number of fetuses are there, whether it's a twin pregnancy, whether it's a multifetal pregnancy, whether it's a singleton pregnancy, what is the chorionicity of the pregnancy, in cases of threatened abortion, and for seeing the nuchal translucency. So for all of these parameters are checked in the first trimester. And what are the other things that can be done where a USG is done in pregnancy? So USG is done as a viability scan or a dating scan between 6 to 8 weeks, wherein we are going to give the expected date of delivery as far as the USG parameters are concerned. We see a nuchal translucency scan that is between 11 to 13 weeks, as I said, in the first trimester. An anomaly scan or a target scan, which is probably the most important scan in the entire pregnancy. And even the Government of India says कि कोई भी अगर scan ना हो पाए, तो at least the anomaly scan or the target scan, as it said, or the booking scan also said in some books, should be definitely done between 18 to 20 weeks. And a growth scan is done between 32 to 34 weeks to check out about the growth of the fetus, see whether any IUGR or any other small for gestational age parameters are there. Okay, so in all pregnant females, a target scan, as I said, should be done between 18 to 22 weeks. It gives you a detailed anatomy to look for gross congenital anomalies. And as I said, if during the entire pregnancy, at least one USG has to be done. If the patient cannot afford for anything more than a one USG, then that one USG has to be this USG, which is the target USG or the target scan or the anomaly scan between 18 to 20 weeks. It's also called a level 2 ultrasound scan, also called an anomaly scan. If fetal echo is needed, in certain cases, in high-risk pregnancies, if we need a fetal echo, it's done between 22 and 24 weeks of pregnancy. 2 questions again. What is the best estimator of gestational age via USG? In the first trimester, the answer is always going to be crown rump length. So anytime the question asks you what is the best parameter for estimation of gestational age, it is crown rump length. In the second trimester, it is biparietal diameter more than head circumference. And in the third trimester, it is the femur length. So 3 questions which have been independently tested before. In T1, it's crown rump length. In second trimester, it's biparietal diameter more than head circumference. And in the third trimester, it is femur length. Now, if you're asked that abdominal circumference is best It is best for assessing the growth of the fetus. That is in case of macrosomia, in case of an IUGR. Abdominal circumference is a very, very good parameter. As I said, we do an echo, we do a USG between 32 to 34 weeks to assess the growth of the fetus, and that is done using the AC parameter. That's the abdominal circumference. Crown rump length is a very important parameter. It can be used up till at least 13 weeks plus 6 days, and the normal, the crown rump length, until the crown rump length is less than 8.4 centimeters or 84 millimeters, we can use crown rump length as a very accurate measure of gestational age. So most accurate gestational age can be measured via the CRL, crown rump length, between 7 to 9 weeks, but it can be, as I said, used up till 13 weeks. That sums up in toto, I guess, the major areas about the first initial half of antenatal investigations and care of a pregnant mother. A weird question was asked once upon a time, I guess 4 or 5 years back, which was probably asked in JIPMER, if I can recall. And it says that what is the gestational age in days of a fetus whose mean sac diameter has been given in millimeters? So just remember, mean sac diameter plus 30 is the gestational age in days. You can remember it, you can choose to not remember it. I just gave you as an information because this was asked before in one of the exams. So that is all for the important antenatal care that we have. I do have certain images with me, but I'm not really sure as to how I can share them. I will be trying to figure out a way in which I can share the images in the next class, where I can show you the different signs of pregnancy on a USG, and I think that will make the class more interactive. That's all for today. It's been roughly around one hour, and I tried to integrate as many important concepts as I could. I hope you'll be sharing this with your friends, and your friends will at least write to me your views and how maybe these sessions can be made better. And I would absolutely love more people joining in, because I have always believed in this, that the more number of people do we have in the form of a virtual discussion platform, we can maybe then have little, quiz sessions from time to time. We can be interacting and maybe even at times taking up doubts related to how to prepare other subjects. As for now, we'll be doing OBS. In the next few days, we will be trying to finish off OBS as much as possible, and I'll be trying to take up the most high yielding areas. So happy learning, keep reading, keep revising, and I hope you have been writing along with me, writing along with whatever I've been saying, and I hope that you've been concising it in 1 page or maybe 1 to 2 page at max, and that is going to be the basis of your revision in the last few days. Happy learning, stay well, stay blessed, all of you. Lots of love, take care, good night.